So, okay, hello everyone. I think that colleagues are joining now. There are about 80 participants today. Welcome to our IANPHI webinar on integrated surveillance during the COVID-19 pandemic. We will explore the challenges of the National Public Health Institute with regard to the implementation of integrated surveillance and surveillance in general during COVID-19. We have several panelists. I will introduce them in a short while, and also Oliver Morgan is joining us from WHO, and I will come back to him as well. I would like to give you some housekeeping rules, first of all. Please do not hesitate to put your question in the Q&A chat box, so we can anticipate your question. Do not hesitate to ask questions, feel free to do so. I would like also to inform you that the webinar is being recorded, and everything will be put on the IANPHI website. And also that thanks to US CDC, simultaneous translation is available in different languages, French, Spanish, and Portuguese. So please use it as necessary. I know it's very helpful for many of us when we are not native English speakers. So now I would like to introduce Oliver Morgan, who is currently the director of the Pandemic and Epidemic Intelligence System for the WHO, based in Berlin. And you can give us more detail about you, Oliver, if you feel needed. You have an extensive experience in epidemiology, and you have worked for WHO since 2016, and previously with US CDC and the UK National Health Service and HPA in UK. So we will have the pleasure to hear a presentation from you on integrated surveillance, and you will then give the floor and have a discussion with our three panelists from different countries and institutions. So Dr. Jennifer Adjemian from US CDC, Jose Paulo Langa from Mozambique, and Muhammad Khan from Pakistan. So this would be for our discussion later today. After this panel discussion, we will have a Q&A with the participants, and take the time to ask questions. And I think we are discussing a very important topic at the present time, where integrated surveillance is so much discussed in different instances, in scientific papers, among donors as well. And after concluding remarks by Oliver Morgan on that part of the webinar, we will have the pleasure to welcome Quentin Sandifer, who is a strategic advisor to the IANPHI Executive Board, but who is also chairing the executive committee of a project which is funded by the Gates Foundation on integrated surveillance. And Quentin will give you a little overview of the project so far and how much it is linked to the discussion we will be having in this webinar. So I give you the floor, Oliver, for your presentation. Many thanks to all the participants. And I would like also to thank Jean-Claude Desenclos, who has helped us to put together the webinar today. Thanks to Marie and Lisa to support the organization as well. So Oliver, the floor is yours.
Thanks very much, Anne-Catherine, and good afternoon or to everybody, or hello from whichever time zone you're connecting from. I will run about 10 minutes and cover some slides to provide some background information about integrated surveillance, and then we will have a panel discussion with our three panelists, who I'll introduce a bit more fully just before we start the panel session. And then there's an opportunity for questions and answers with all of you who are connected online. And we ask that you put your questions into the Q&A box of Zoom and ask questions that way. We have simultaneous translation, as Anne-Catherine mentioned as well. And so I hope that you'll be able to follow along in multiple languages. We'll see how we manage the questions. I think please write in the language you're most comfortable with, and we'll manage the questions in that way. So let me just bring up my slides just to give a very quick background overview, and maybe Anne-Catherine, you can confirm once they're in presentation mode.
Yeah, you need to put it on a slide mode.
Screen, okay.
Yeah, because we see the slide on the side, so you need to. Diaporama is in French, but the slideshow mode. Yeah,
I'm hoping that now you see it. Okay, great. Thank you very much. So these are just a few thoughts. As Anne-Catherine mentioned, integrated surveillance is a topic that's discussed a lot, of course, at the moment. And it's great, actually, to see renewed interest in this topic. But the origins of surveillance are all familiar to us as public health professionals, going back to that key investigation by John Snow all the way back in the end of the 1800s, where he tracked cases of cholera and actively looked for those cases, and in effect conducted the first epidemiologic surveillance of for infectious diseases, which then progressed rather unchanged, to be honest, over the subsequent 100 or 150 years. Yes, and really today, surveillance of cases or case identification is really still the foundation of public health surveillance. Here is an example from global influenza surveillance, and really this is just a large-scale version of what John Snow was doing, maybe with some additional sophistication. But in essence, it's really the same, which is identifying cases and counting those cases against a standard case definition. Now, there have been obviously advances in the application of this approach, and possibly the biggest change in the way that public health surveillance was conducted and used was initiated by Alex Langmuir in the United States in the 1950s. And what Langmuir did was really connect the data that came out of surveillance systems with action, public health action on the ground. In that context, it was in polio eradication in the United States, and then subsequently for control of other vaccine preventable diseases. But this is really where a lot of the integrated thinking really started, was taking what was previously a fairly passive approach of surveillance of infectious diseases, which usually resulted in statistical summaries or statistical bulletins published periodically, and was transformed by Alex Langmuir as really an intelligence process to inform disease control measures on the ground. And modern public health surveillance can really trace the integration between surveillance and response back to the 1950s and Alex Langmuir's work. Now, another revolution happened in public health surveillance, somewhat quietly, and like many significant changes, it's not always apparent at the time. But in the 1990s, we had the establishment of ProMed by Stephen Morse, Jack Woodall, and Barbara Hatch Rosenberg. And this was really a transformative moment in modern public health surveillance. And what they did was seemingly quite simple, which was to use email, which was a new technology at the time, to encourage people working in public health around the world to share information about what was happening. And the reason why this was such a transformative moment was that not only were they applying new technology, which that trend has obviously continued, but it was really the beginning of the participation of non-government sources in reporting public health data. So unofficial data or unofficial sources being used to report outbreaks of diseases. And as you'll all be familiar, ProMed is still going strong, and it's still really a fundamental component in the global surveillance architecture for all of us today, and has opened up a very important aspect of public health surveillance, which is the combination of both official public health surveillance data and unofficial reporting from a variety of sources to complement official public health statistics. At about the same time, interestingly, there was also another very important event, this time important from a WHO perspective, which was a plague outbreak in India, in Surat, India. And this event caused widespread panic, not only in India, but also around the world, with many people traveling out of the affected area and traveling widely across the country, but also a severe disruption in the tourist industry to India, and a real disruption in passenger travel from around the world to India because of the concern about this outbreak. And this led to a realization that that WHO needed a different approach, that the passive surveillance approach wasn't sufficient to detect new events occurring around the world. And in 1994, WHO established a disease intelligence unit, which was really the foundation of what we really currently do today at the global level, which again is this integration of a number of different information sources, both officially and unofficially, with the goal of detecting occurrences of diseases as quickly as possible and responding wherever they may occur as fast as we can. In the subsequent 25 years, we've seen a steady investment and development of different technologies and different platforms from different parts of the world, using a number of approaches which are largely based on open sources. And really the work between GFIN, the Global Public Health Intelligence Network, created by the Public Health Agency of Canada and WHO at the end of the 1990s, really was a kind of a third big change in the way that surveillance is being conducted. And this approach gathers information that's available through publicly available sources, mostly that are available online, and uses modern machine learning approaches to manage large quantities of data to identify potential signals of public health events. And these approaches continue to grow. The EIOS initiative, the Epidemic Intelligence from Open Sources initiative, which has really been the next kind of evolutionary development in this approach, now includes about 50 different countries and institutions around the world, all working together, sharing information about public health surveillance. And so again, this is a growing and developing area. One of the key documents or the key initiatives that many people refer to when they're talking about integrated disease surveillance is the IDSR strategy in the Africa region. This is the latest, the third edition that was published, I forget, I think in 2018 or 2019. And when talking about the integration aspect, really the IDSR strategy covers the integration of a large number of surveillance elements from the surveillance systems and the different information systems, as well as integration of laboratory resources, integration between surveillance and response, and also the integration of surveillance with management and coordination functions in public health. So the term integration here for the IDSR strategy is quite a broadly used term, and sometimes we can find ourselves talking about different types of integration, and that'll be maybe a theme that we can explore during the panel discussion. That being said, I think there's still quite a number of areas where integrated surveillance is still maybe quite weak, actually. Last year, a group of us published a paper which tried to identify some of the domains which are particularly important for building future surveillance systems or stronger integrated disease surveillance systems. And in this paper, we included this little table which identified these 5 areas: population-based, that surveillance systems should be population-based, should have laboratory confirmation, the data should be digital, there should be data transparency in as much as there is sharing of those data, and there should be adequate financing to sustain the surveillance systems into the future. And we propose that these 5 areas are critical areas for developing integrated disease surveillance for all countries and at the regional and global levels for the future. And so my final slide, before we turn to the panel, is really just a mention about where I am sitting, which is in Berlin, in the WHO Hub for Pandemic and Epidemic Intelligence. And this is a significant initiative by WHO and other partners to really focus on building stronger integrated surveillance around the world at all levels from countries all the way up to the global level. And we also have a concept of integration, which also includes the integration of different types of data, but also across different aspects or different phases of the emergency response cycle, so that the surveillance and intelligence functions are not conceptually implemented in a linear way, but are implemented on a continuous basis. And that integration with response continues to be a strong emphasis that we have here with the WHO Pandemic Hub. So thank you very much for the opportunity just to provide some background. We will now turn to our panelists and start the panel discussion. I will introduce the panel. If you bear with me, I just refer to my notes. We have 3 excellent panelists who've joined us today. We have Jennifer Adjemian from the US CDC, who is the acting director at the Division of Health Informatics and Surveillance. And Jennifer oversees activities for the National Notifiable Disease Surveillance System and the National Syndromic Surveillance Program in the United States. We have Mohammed Khan, who's the head of the Transformation and Excellence Center for Health and the National Health Data Center at the Pakistan National Institute of Health, and which aims to develop digital health solutions and implement those solutions and provide training and support. And we have Jose Paulo Langa, who is the head of Surveillance and Surveys Department at the National Institute of Health in Mozambique. And Jose Paulo has been an international auditor for the strengthening of laboratory management for clinical and public health laboratories since 2012. So welcome to the panelists. Thank you very much for joining. I think you might be happy to turn on your cameras now, and we'll jump into the first part of the panel session. We'll start off with a question to each of the panelists for about a 5-minute response from each panelist, and then we'll open for some questions and answers, question and answer session. So for colleagues who are joined online, please put your questions into the Q&A function in Zoom as we go through. So for the first question, so in terms of impacts of the pandemic, what weaknesses and gaps in the national surveillance systems were revealed by the pandemic? Are these problems new, or did some of them already exist before the pandemic? And what are the nature of these weaknesses? Are they structural? Are they weaknesses in governance? Is it about capacity, resources, integration, policy, or all of those areas and more? So I'll first turn to Jennifer to provide some thoughts on that question.
Sure. Thanks so much for the opportunity to be here and discuss all of these topics. And I will agree with all of the above. Again, I am representing Centers for Disease Control and Prevention in the United States here. Many of the challenges that we have had with surveillance, and especially when you talk about integrated surveillance, were definitely highlighted during the COVID pandemic. I think, as was mentioned, so we have two major surveillance programs that run national surveillance activities that I oversee. So this includes the National Notifiable Disease Surveillance System, where we have a list of approximately 120 conditions that are immediately reportable when a case is identified to CDC. And then in addition to that, we also run the National Syndromic Surveillance Program, where we probably have made a little bit more progress in that side with integrated analytics and surveillance. But there we work to receive emergency department data from over 70% of hospitals in the United States within 24 to 48 hours of the visit occurring. And that includes a variety of data elements that allow us to use machine learning approaches and other analytic tools to be able to rapidly identify public health events of concern. In addition to that, we actively bring in mortality data. We also work to bring in commercial laboratory data. And again, with all these data sources that we're bringing in, we're able to potentially look at them in conjunction with each other. But I would argue that that's still different from where we're trying to go in an integrated approach, where we want to make sure that we can actually link data and get the full ecosystem of what's taking place with case surveillance. The challenges that we have that stand out most in the United States are, first and foremost, we are a federated system. So each state, each jurisdiction at that state and local level technically has the authority to do its own thing. They collect data in different ways. They use different approaches. They have different purposes for why they're collecting data. And then on top of that, CDC does not have the authority to directly receive data without doing so through data use agreements set up with each separate jurisdiction, as well as with trusted partnerships and relationships that we have to be very careful in developing and cultivating to make sure that we are using their data in a responsible way. So all of those different challenges make it more difficult to have a national aggregated picture of surveillance in this country. And you can imagine when there's a public health emergency such as COVID, everyone wants answers yesterday. So some of the challenges here is, as we're bringing in all these data from different approaches and sources, there's a ton of manual work that's needed in order to clean the data and be able to look at them in conjunction with each other. So I would say that those are some of the greatest challenges we have. Those challenges exist because of laws that are in place, politics that exist, cultural practices, all of the above, essentially. I would say that the technology is probably the easiest piece to overcome and fix. It's all of these other challenges that I think keep us in the position that we're in. That being said, COVID has brought us into a new era of the overall desire and motivation to move us into a modernized approach with how we work with data and integrated analytics, especially for surveillance. And so I would say more than ever, we have the visibility, resources, and support to be making major changes that I think are going to help us overcome a lot of the issues that we had to contend with during the COVID pandemic. So I'm cautiously optimistic that we are moving in the right direction there. But at the same time, I think the key to being successful is always going to be making sure that we're tying the data back to public health action at the local level, because that's what's going to have the impact that we're hoping to see.
Great. Thanks so much, Jennifer. A huge task ahead of you for sure. It'd be great to see how that develops over the next few years. Maybe we can get the perspective from Pakistan and over to Mohammed for the same question.
Hi. Well, firstly, your presentation was very good, very informative. And I would request you if you can share the copy of it after this session. Secondly, I would like to say thank you for giving me a chance to represent my country, Pakistan, my organization, NIH, on this platform. I feel honored. Thank you for that. Now, coming back to your question, I think several gaps in the national surveillance system were reviewed, let out by the pandemic. And these gaps exposed the structural governance, capacity, integration, resources, weaknesses that Pakistan faced. And we never had even 1% of GDP to health. So one can easily imagine our situation at that time. It was really tough. Then the idea of disease surveillance or initiative, whatever you call it, was ignored in the past, maybe due to lack of understanding of interest. So I think Pakistan was at that time already facing a huge shortage of doctors and paramedical staff with its increasing population size. So we have less than 1,000 physicians per 1 million people. And most of our local health care facilities have no functional healthcare system and administrative infrastructure. So I can comfortably say that we were brutally unprepared for a pandemic at the scale of COVID-19, with inadequate diagnostic testing capacity, protective equipment, contact tracing, quarantine capacity, technical expertise, guidelines, SOPs, and so forth. Then we had this another big challenge at that time. It still exists, though, that the 18th Amendment to the Constitution empowered provinces to have to manage their own healthcare delivery system. So with this, we faced severe challenges in coordinating national level surveillance and response. The provinces developed their own fragmented disease surveillance system, operational in silos, with similar issues pertaining to adequate resources and finances. Therefore, I think to address all these concerns and coordinate a national response, we here at Pakistan, we established a National Command and Operations Center for better provincial and facility level coordination. It is actually created in line with the Pakistan National Action Plan. And this plan, this establishment of NCOC actually strengthened and reduced gaps in coordination at all levels. So this really helped us. But we had problems at that time regarding integrated or any kind of surveillance. And the most important was to bring data from all over Pakistan and combine the data and make it more usable. So we did that with the help of this NCOC and the other setups. So it really worked for us. So we had challenges at that time. Thanks.
Great. Thank you so much, Mohammed, for sharing some of those insights and considerable challenges that it sounds like you made quite a lot of progress to overcome. And I think this is a positive theme coming through the pandemic. In many countries, is quite a lot of progress has been made, even if it was under extreme pressure. Maybe we can turn over to Jose Paulo to hear about the experiences in Mozambique.
Thank you. I would like to first thank you for having me here. Just for the sake of connection, I will just switch off my camera. So just to improve the way you will receive what I'm going to say. Well, going straight to the question, I mean, the weakness, I think that was the common weakness around the world was readiness of the surveillance systems. Although we have all this development within the surveillance world, the epidemiology world, surveillance, they use normally, or they were working normally on the basis of John Snow methods, identify cases and respond on a classical way. And this, I think, for us as Mozambique, that was a weakness, but also it was a very big opportunity. So being from National Institute of Health, we were also building new ways of doing surveillance. And when pandemic came, those classical ways of doing surveillance would not be sensitive enough to identify case, to trace, to do a contact tracing, mostly because normally in public health, we are only using, or we are mostly using sources from the health sectors and use very less information from other sectors. And health sectors are not that very much developed in our country, and only using this data from health sectors would not help much to manage the pandemic. This was a very big weakness, and opportunity came that we could use different sources from other sector, like our telecommunications, using data to trace people, to find where they were, and use health observation as a platform to integrate data and better respond to what we were seeing. But this was also also opportunity and weakness again, because as you said on one of your slides, data transparency are not very elaborated and available so that we can use as we should to improve our actions. That was a big weakness. Sharing data that we could use, when we could use, we could see that was useful to respond. And all this integration concept, what is integrated, it was also a very big issue, because we had a lot of platforms being developed and in place, and to integrate, there was a little bit of confusion if we are integrating the platforms, if we are integrating the systems or the information they generate. So this was a very big weakness. And I would say this is a not new problem. I think we on the past years, this has been the discussion about what is integration, which system to use to better to give us a better information and allow us to respond well. And I would say it's structure and resource also. We are a low-income country, so resources are very critical here to build systems and to choose systems. So we would choose those systems that normally would have some resource to maintain or to sustain the system throughout the management of the pandemic. And in one last root of the problem, I would say it's integration. This concept of integration, you made such a nice presentation. This concept of integration, I think it's not throughout clear to all parts, you know. So I mean, it can be clear to the lab people how to integrate lab information, and to the epidemiology team can be also clear. But when we come to integrate all this data, even data that are not coming from the health sector, then it becomes to be a little bit complicated. So I will stop here. Thank you.
Thanks so much, Jose Paulo. I think we all can share some of the challenges that that you faced certainly in Mozambique. I think were really faced in all countries. And just a mention as well, I mean, there is a big integration problem, you know, at the supranational level or at the international level. And I had the terrifying job of putting together the data from 194 plus countries every day, twice a day for WHO for about 2 years. And that integration is a real problem, I can tell you. And so, and unfortunately, we see the same problems when integrating data when there are outbreaks that happen across multiple countries. We have several of those happening right now, and we have the same integration problems as we did at the beginning of the pandemic. So we still have a lot of work to do. So great. Well, thank you very much for those answers. We'll turn to some questions and from the participants online. I'll turn to the Q&A box first. I think some people have had put questions in the chat. If you can repost them in the Q&A function, that will help me a little bit manage here. So maybe I'll just take them in order. And there's a question for Jennifer about how data are reported from the state level to CDC. Is there an electronic system in place to manage that?
Yeah, thank you for the question. Yes, data are sent in electronically, but in a variety of different formats that still need to be integrated once they are received by CDC. Some of the challenges in the pandemic, as well as anytime there's a new public health event, is that there isn't a mechanism by which new emerging conditions can automatically be sent to CDC. Beyond that, we're often trying to get a lot of the details to help us do investigations, better understand what kind of interventions are needed to help at that local level. And so for that reason, there could be a lot of requests for additional information that are maybe not already ready in a standardized format. So at the local level, there's a lot of manual work that often has to happen in order to receive the information CDC is requesting. One of the things we're really trying to do is to automate that as much as possible. We're trying to do a much better job pulling data from electronic health records. We have major pushes forward for electronic case reporting. A lot of the lab data, which I mentioned, is already sent to us in electronic formats. But again, linking that to that case information and making sure that that's made back available for epidemiologists at the local level to act on is a piece that I think is still challenging and still missing. In addition to that, each state often uses a different surveillance system. So as we try to encourage standardized submission of data electronically, we're almost working on not even a state-by-state basis, but even within states, each condition sometimes is in its own silo for how we're trying to receive data. So yes, broadly it's electronic, but there's still so much manual work that's needed that we feel could be automated to help move that forward. So that is the goal that we have set for us right now.
Yeah, thanks, Jennifer. You know, interesting. I think many countries face that same challenge, and there isn't really an obvious relationship between a country's GDP and the level of sophistication of their public health surveillance system, and that is. I think makes this conversation particularly relevant because really all countries could make significant progress in their public health surveillance systems. And this is a challenge that faces many countries, probably all countries around the world at the moment. I have a question in the Q&A box for, I think this is for Jose Paulo, about your comment about data transparency internally in Mozambique, and why was that an issue at the national level?
Oh, thank you. I mean, it was an issue because, as I said, the system was not prepared to, this pandemic showed that immigration data, for instance, was critical to control the pandemic in country. It was critical to know where people are or from where people are coming from. And immigration service, it's a, how can I say, it's a paramilitary service. So they treat information in a different way. So they were not trained which level of information they can share. So we are also not trained about which level of information we would request from other systems to integrate on ours to produce a better result. So when they would provide us with information, or when systems start talking under this pressure of the pandemic, they would provide what they think it's useful to other systems to work, but not necessarily. So then we start talking about transparency. So what I see that as a way forward, and as I mentioned before, we have this health observation platform, which is which looks like with what you presented on in one of your slides, to analyze data together, data from different sources, producing analysis, and this analysis is the information that is useful for different systems. So yeah, I would say I would respond like that.
Great, thanks, Jose Paulo. Sorry, I had a bit of trouble getting off mute. Mohammed, in Pakistan, I imagine you have the same challenge. You've mentioned let's say the independent approaches taken by the provinces throughout Pakistan. How was the data transparency issues for you? And maybe if you have any reflections about whether the polio surveillance program in Pakistan was helpful in trying to resolve some of those challenges.
As I've already talked about the 18th Amendment, that there was no central body for overseeing the pandemic management. And as the research proves that those countries which worked on the model of public health emergency operations center were better able to manage the pandemic. So we formed NCOC. I mean, but again, the main issue was when we started to developing some products to cater resource management system, vaccine record administration, its administration record, inventory management, contact tracing, and so on. At that time, a cross-functional coordination with multiple stakeholders like ministries, NADRA, National IT Board, NIH, helped in developing those systems. But what was happening before that we have data, we have people who have data, but the point is that the data is sponsored by so many, there are so many players in Pakistan who are funding some small big parties that they are producing some kind of data. So then the data transparency that I mean, nobody is, I'll give you a very basic, straightforward example that maybe if I want data from some province from Pakistan, I might not get the data directly from them. I have to request maybe WHO for that data. So, so then people definitely question that the data might not be that transparent. But yes, with this pandemic, we managed to build some very strong systems, very reliable system. For example, we have this national immunization management system, which was developed by NADRA, and it's being used for vaccine administration. I mean, this is a wonderful, perfect system. Even the polio, now we have added a polio module in it as well. So it will give the polio data as well. So in one system you have COVID data, you have polio data, and maybe there's some other disease like yellow fever, and they will add more diseases sooner. Then we have this COVID system. COVID was it helped with in inventory management of COVID vaccines. Similarly, resource management system. RMS helped in tracking essential resources like beds and oxygen availability, which was very important at that time. Then we had the fast track application, yes, which was actually used to record and track international air travel. So yes, transparency definitely matters, but I think that digitization of system, it really helped us in the pandemic. Reason being, like those we talk about smart lockdowns and other restrictions, they were all based on data from digitized systems. Well, definitely we requested many stakeholders for that data. So we started, and we got those that data finally, and those hotspots, but they were being prepared with data sets from various stakeholders like provincial management cells and Pakistan Bureau of Statistics. So and again, one more thing, at that time we also witnessed a mushroom growth of telemedicine platforms, but they were all operational at that time in silos, even now. And I think that it's a great loss. Reason is that when such data cannot be analyzed and then shared with the decision makers, until then it is, I think it's of no use. It's garbage. So we learned a lot. We are still learning though, and but we have already realized the true value of data. And what we are doing here in NIH right now is we have this a mandate, as per the mandate given to in the NIH Act 2021, we have established a National Health Data Center, and we aim to bring all health data streams under one roof. We are also developing a national health decision support system. I mean, this system will tie up all these data streams together, add some BI and AI tools to it for maybe future trends or alert generation, and then forward the results to the decision makers in the form of a consolidated dashboard. So again, if I think that masses should know that the data, we should tell them that the data can be, the process should be transparent in order if we need their support to get out of any kind of outbreak of pandemic. So data transparency, it does matter, but the thing is that we need to work together. We need to bring all the stakeholders, the priority stakeholders or anyone on one board, and we need to discuss with them that with the data, with the results of the data, the more accurate, the more realistic data, that can really make a difference. So for that, we need to bring everyone on same page. That is very important in my view. And again, one more thing, what we are doing right now is, like I have told you, that we have realized the value of data. I think in Pakistan, what we need is a national health ecosystem. I mean, every single lab, hospital, clinic, whatever you call it, should be connected digitally. So, and I mean, I know that is not possible if you say that we can do it like in 6 months or 1 year. It will take some time, but this should be our approach. And this is how, I mean, we are working on. So let's hope for the best. We are doing our best. We need we get funds from different international organizations, thanks to all of them. And again, we might get funds from the government as well. So whatever we are getting, we are trying to approach the low-hanging fruit first, and trying to build something on it. So then we can show that kind of a pilot and model to the decision makers, or to those who are willing to spend something on data. So I think time will tell, but definitely our approach is fine. We are going the right path, and hopefully very soon, in a very small time, we will achieve some good goals.
That's great, and I think the idea of the National Data Center is a really interesting one, and leveraging the tools. And I think we'd all agree with you that digitally connecting as many parts of our healthcare systems as possible, it should be an achievable goal looking into the future. I think this is where we should all be heading. And we have a few more questions coming in. I'm going to combine two questions and use it as a kind of bit of a wrap up. So I'll ask each of the three panelists to answer this final question. And I'm going to combine a question from Helen Perry. Hey, Helen. Helen and I used to sit in offices next to each other many years ago. It's lovely to see you in this forum. And a a question from Leah, and kind of combining those two questions, it's really about what should we consider as some initial steps at the subnational level to strengthen our integrated systems. So where can we invest subnationally as a starting point so that our systems can be better integrated up to the national level, and I guess beyond up to the regional and global levels. So maybe I would turn that to Jennifer for a couple of minutes each, and then we'll wrap up the panel discussion. Thanks, Jennifer.
Sure, sounds good. So one of the things that stands out to us that's really critical for strengthening practices at the local level is related to staffing support. It's not just enough to provide financial resources. These locations often have a very challenging time recruiting the kind of staff who have the expertise in health informatics principles to even be able to implement any national standards or improving the electronic flow of data to CDC. So one of the things we're really trying to do, well, actually, it's a twofold approach. First of all, we're trying to improve a surveillance system that we can make available to jurisdictions that's going to incorporate a lot of our data modernization approaches, the integrated surveillance and analytic approaches, be able to automate things from their end as much as possible and improve standardization of data. There's a system that there are many different surveillance systems that states currently use, but there's one that's developed by CDC that we're currently trying to focus on, employing a lot of these concepts so that we can have a really large impact at a quicker rate for many different jurisdictions that use that system. So that's one approach. And this needs to incorporate tools such as alerts to the data to help direct their attention to when the data are saying, hey, there's something going on here, knowing that people don't always have the ability or time to focus in on each particular record that's coming in. Another important feature and tool that we feel is going to be critical at that local level is assisting in case investigations and case finding and being able to link cases so that when someone's under investigation, they're able to track that in the same exact surveillance system that they then use to send data to CDC. Ultimately, we want things to be as much of a one-stop shop as possible for locals and states to be able to not have redundancy and not have to duplicate efforts for what CDC is requesting based on what their local needs are. So that's a huge goal for us. And then, of course, trying to improve our ability to share resources with staffing to local levels to help them implement these approaches. And in terms of areas that are particularly successful in doing this right now, we're trying to get some lessons learned. There are some states in this country that have done a phenomenal job with integrating their data. So right now we have a major national effort to learn from them to be able to start incorporating that into the principles that I was just mentioning that we could share hopefully at the national level.
Great, thanks so much, Jennifer. And over to you, Mohammed. I know you've covered many of these points already and discussed the National Data Center, but at the local level, a couple of initial steps that Pakistan might be able to take to strengthen the integrated surveillance.
Yes, I've already told that we have this mandate now. Nobody is going to say no to us. But definitely, when you go in your provinces and you talk to them and you ask them the data, for that they need some kind of incentive, a reward, and like it is already it has been mentioned already that data, you can get a quality data if you have quality surveillance and response systems. Otherwise, so we need to strengthen the people, those people as well. So firstly, if you go to subnational level, you need to make sure that the surveillance is of good quality, and transparency is there again. The same issues is like in every other country. So my point, and the government should also be very transparent in the process of the authorities in order to engage citizens to the cause. So if we need to engage everyone, we need to bring them together. So we need to tell them the cause, what we are actually doing. But there are certain elements. There are many of them who want some kind of benefit from that. So what we do is we go to the subnational level. We talk to the DGs and other people, and we make sure that they instruct those people what we actually want from them. So I mean, this is how it works here. But right now, again, we have this a power button with us, that we have this mandate. Ministry of Health is with us, even wherever we are going, they are with us. So because they know that all data streams should be here. They didn't give us any deadline, but definitely we have this 1-year plan ready to show. I might share with you or with the IANPHI, and so that everybody should know that what we are planning for this coming year. So hopefully it's very detailed and comprehensive. I cannot explain everything here right now, but definitely I think better surveillance will give better data. For better surveillance, you need to go, you need to work with them, you need to sit with them, you need to listen to their problems as well. And mostly they have resource problems. But no, there is no permanent resource. I mean, if there is, for example, let's say that we have some successful projects sponsored by different organizations, international organizations. But that sustainable growth is often hampered due to limited or lack of funding provided by the government. I mean, we cannot ask for the funds every time from the international donors. We need to have something from our government side as well. So we have worked on that as well. We have allocated some funds for federal and provincial levels as well. But how to utilize those funds, how to move forward with those funds, that is really important. And for that, again, one thing is for sure, we all need to sit together. We all need to discuss the plan and move forward.
Great, thanks, Mohammed. The costing issue is enormously challenging. In the paper I mentioned, we tried to cost out what we think the right amount of investment is needed, but to be honest, it was really, really tough, which is one of the problems for surveillance, making the business case. Let me turn to Jose Paulo about thoughts from Mozambique, some subnational steps that you can take to get stronger surveillance.
Thank you. So, I mean, we are in this process of giving the steps to build stronger surveillance, and part of that, it's also changing the view that we have about health surveillance, bringing new elements to the surveillance role. How can we multidisciplinary work together to improve better surveillance? So with the pandemic, we did well at national level. Now going down to subnational level, to local levels. I mean, well, we think that improving the capacity, abilities of the staffing, as mentioned by my colleague before, in local, in subnational places, is the way forward. So we need to give them abilities to analyze this data, to collect data with quality, and give them this vision that health, it's not only in health sector, but it's a combination of multi-factors that will combine to a better information, and that will move us forward. So as I mentioned before, so it's a very strong work by the National Institute of Health, this concept of health observation platforms as a platform to integrate system information and data, so producing this integrated surveillance system. So we should take this to the lower levels, train the lower levels, habilitate them to perform by themselves. I mean, we are a low-income country, so resource will always be a problem. So we should find innovative ways to overcome these challenges and move forward. And one way to move forward is train well our staff, so that with what they have, they can bring quality, and together they can work together to bring this integration in the base, and then move up to the national to the national level. So this is, I think, what I would say.
Great, thanks so much, Jose Paulo. That's super helpful from all of the panelists. Let me just say a big thank you to the three of you for joining today. We could keep going, but we're out of time. I think just a final reflection for me is that the national coordination is clearly something that is critically important. We've heard that from the three of you. Technology is one thing, but the coordination is probably the most critical piece at this point for moving forward. So congratulations to you all working in that space. And I'm going to turn straight over to Quentin Sandifer to also talk about the IANPHI IDSR program. Over to you, Quentin.
Yeah, thank you very much, Oliver. Well, look, I'll be as brief now as I think I'm into extra time, as they say in football. On behalf of IANPHI, I'm very pleased to just briefly tell people about a project that we're undertaking with the WHO Hub for in Berlin for pandemic and epidemic intelligence, and also in close collaboration with the Robert Koch Institute. IANPHI received a grant from the Bill and Melinda Gates Foundation earlier this year to support understanding on integrated disease surveillance from the perspective of national public health institutes. And as you know, IANPHI has members, 111 members across the world. So apologies that I wasn't able to join the discussion a little bit earlier. There are just 4 elements to our program of work. I say just 4. There are 4 areas that we're working on. The first is to undertake a rapid review of the available literature. We're looking at primary studies and other studies as well. That work is well advanced, and we're hoping that the data collection will be complete this week. We'll undertake analysis, and hopefully the report of that will be written up during July. The second is a survey of the membership of IANPHI, the 111 institute members, and letters already gone out to all the member chief executives or directors general, asking them to nominate a focal point who will coordinate the completion of those questionnaires, and we're hoping for a good response. Now that questionnaire is in the final stages of development. It'll undergo, hopefully within the next week or 2, a piloting with several institutes that have been identified now, and then it'll go out to members in the next couple of weeks for a 4-week response time, and then during the second part of July, August, we will start collating and analysing the information with a view to writing the report up during August. The most challenging part is to undertake some in-country deep dives, and we are continuing our discussions at the moment, but we've got, I think, very promising tentative commitments now from Pakistan, Malawi, Mozambique, and those we anticipate through our membership of our members we will secure in the next few days, week or so. Malawi has even gone so far as to set some dates in August. We anticipate those will happen in August. We are in discussions through the CDC with a number of other countries, including Ecuador, Uganda, and Sierra Leone. And we're hopeful that Ecuador will come on board to give us a Latin American country. In addition to that, we will do also some additional deep dive survey work with some high-income countries and the United Kingdom, HSA, Saudi Arabia, and have both been identified together with Sweden for that part of the survey. The last bit then, the 4th work stream is yet to be fully bottomed out. We were asked by the Bill and Melinda Gates Foundation as one of the conditions for the grant, to liaise closely with the Resolve to Save Lives, which we have been doing. And we have a further meeting with them in the next few days, and we hope we'll confirm the terms of reference for that particular work stream and undertake that in due course. The overall timetable is very tight. We expect most of the report writing to be done in September. We're aiming to complete our analysis and report writing in September, and in early October we plan to meet up with partner agencies to share our findings. This is just in advance of the World Health Summit. That's it. Thank you very much for your indulgence.
Thank you, Quentin, for your explanation about this important project for IANPHI. And maybe we are 6 minutes late, so I will stop there. And I would like to thank everyone to have participated so actively. Thanks to the panelists, thanks to Oliver, thanks to Quentin to have joined at the end of the seminar to deliver important information for our members as well. And see you soon in our next IANPHI webinar. Just to remind you that everything will be put on the website. So the recording will be available on the website for everyone to see. Thanks a lot, and good afternoon or good morning or good evening, depending where you are. Bye.